Hello, my name is Dancy Jacobson, and I am an assistant professor of emergency medicine at the Medical College of Wisconsin, where I am an ED medical director and the system director for quality, safety, and experience. And today we're going to talk about how do we measure quality in the emergency department. Specifically, we will cover what is quality, how is a quality metric measured, and how is a quality metric determined. First, I'd like to go over a few definitions. Quality is different from safety, even though the two terms are often interchanged. Quality refers to metrics and measures established to determine a standard expectation of care for defined conditions and pathologies. This is what is often measured by metrics or measures. Meanwhile, safety refers to patient safety. This is often determined in individual case reviews that are submitted cases for peer review. And specifically in healthcare, safety refers to examining specific cases for system-based or human-based errors. The Institute of Medicine summarizes the definition of quality nicely when they say quality of care is the degree to which health services for individuals and populations increase the likelihood of a desired health outcome and are consistent with current professional knowledge. The Institute of Medicine has also defined 6 domains of healthcare quality. High quality care is safe, meaning that it avoids error or injury. It is effective, meaning that we're avoiding overuse or underuse of resources. It is patient-centered, meaning that it's respectful of patient autonomy and goals of care, and that it is responsive care. High quality care is timely, reducing harmful delays. It is efficient, meaning that it avoids waste, in particular waste of equipment, supplies, ideas, and energy. And importantly, high quality care is equitable, meaning that high quality care does not vary in quality because of personal characteristics. As previously mentioned, quality is measured using metrics. Metrics are well-defined performance measurements that are used to monitor, analyze, and optimize healthcare processes in order to optimize patient care. Metrics may be tracked as percentages, absolute numbers, and measures of time. It is important when tracking any metric or measure to define the metric well in a durable definition that does not change over time, and also decide a consistent unit of measurement. For example, if you are trying to measure and track ED length of stay over time, you may define ED length of stay as the total time that the patient spends in the emergency department, or as the time from arrival to the time of disposition decision. It will be important to have a consistent definition so that tracking is consistent over time. Additionally, time can be measured in a number of units in a number of ways. It may seem simple to track ED length of stay in minutes. However, when reporting out over time, it will be important to determine if you plan to report out the average ED length of stay as a mean of the number of minutes a patient is in the ED, or the median ED length of stay. Additionally, time-based metrics are also often reported out in percent outliers or percent not at goal, meaning what percent of patients are in the ED longer than a previously determined goal length of stay. As you can see, what may seem simple in the beginning becomes complex very quickly, so it is important to determine consistent definitions early and have a common understanding with other key parties who are measuring the metric as well. Speaking of important key parties, Who decides what metrics to measure and which ones are most important? There are many organizations involved in healthcare quality assurance in the United States. In the ED, common organizations involved in quality assurance include the Centers for Medicare and Medicaid Services, the ACGME, the Joint Commission for Accreditation of Healthcare Organizations, and the AHRQ, which is the Agency of Healthcare Research and Quality. Additionally, there's the American Board of Emergency Medicine and professional societies such as the Society for Academic Emergency Medicine and the American College of Emergency Physicians. There are additionally accreditation programs such as the Trauma Accreditation Program, Stroke Accreditation Program, and others. Additionally, hospital and institutional quality offices likely help determine what quality measures are tracked in any emergency department. Some measures that may be tracked by hospitals might include readmission rate. Additionally, ED department leadership can choose metrics or measures that are important to their department. And these may vary based on the clinical practice environment, the healthcare organization, and even recent quality and safety trends in any given department. Some commonly tracked measures in the emergency department include deaths in the ED or within a certain amount of time from admission from the ED. 72-hour returns to the ED, either with or without admission. Transfers from the floor to the ICU within a certain time frame of ED admission. There are also condition-based measures, such as for stroke, STEMI, and sepsis. For example, for stroke patients, commonly tracked measures include time from door to CT scan or time from door to thrombolytic therapy. For STEMI, commonly tracked measures include door to EKG, EKG to interpretation, and importantly, door to catheterization. For sepsis, commonly tracked measures are determined by CMS, where there are core quality sepsis criteria, some of which include fluid resuscitation, antibiotics, obtaining blood cultures, and obtaining an initial and repeat lactic acid, all within certain timeframes. Individual departments may track the number of occurrences or specific content of safety events or patient grievances. And as we have discussed, there are multiple time-based measures, such as door to doctor or total ED length of stay. Remember that any metric can be decided upon and measured by an emergency department or operational leaders. However, there are a few core pieces that make up a good metric. Some of the important aspects are that a good metric is comparative. You're able to compare it to itself over time to reliably look for trends and so that everyone's speaking the common language. A good metric is understandable, and a good metric is behavior changing and impactful. That means that by tracking a metric or a measure over time, you're hoping to impact change, and that change, hopefully, has a positive impact on patient-centered outcomes. The next lecture in this series will go over a more in-depth overview of how to track a metric in emergency medicine and how quality assurance works in the ED. However, briefly, how to track a metric in the ED. It will be important to, once you have determined what metric you're going to track and defined that measure well, you'll have to identify the source of data. This is often an electronic health record or an accreditation database. It's important to identify key parties early. This might include both the group of people whose behavior you are measuring, and then perhaps an audience that is driving the quality measure or requiring tracking, such as organizational quality offices or accrediting bodies. Additionally, you'll have to identify a cadence, meaning, are you going to track this over weeks, months, or quarters? And once you decide how frequently you're going to report out on the metric, you will have to develop a report out structure. This may look like an ED quality dashboard. There may be a quality committee that meets monthly or quarterly. You may have a database that you use, or it may be reported to frontline faculty, fellows, residents, and APPs in a quality newsletter. But regardless, it will be important to understand the source of data, the key parties involved, how often you're reporting out, and develop a structure for reporting out. Again, all this information will be covered in more detail in a subsequent lecture. Thank you for your attention during this brief overview of how do we measure quality in the emergency department. Thank you.